Welcome to the deep dive. Today, we're really plunging into some complex stuff, cystic lesions and disorders in the oral and maxillofacial region.
Yeah, it's quite a topic.
Definitely. This deep dive is for you if you're curious and want to get up to speed on these structures, not just what they are, but, why they grow and how doctors figure out the best way to treat them.
Right. And this part of the body, it's fascinating for pathology. It's full of these leftover bits from development that can, well, sometimes cause trouble.
Leftover bits, okay.
So our mission today is to clarify the key structures, really get into the physics, which is surprisingly elegant behind how they expand, and importantly, tell the difference between the common ones and the, let's say, higher risk types you find in the jawbone and salivary glands.
Okay, let's unpack that straight away. When we hear cyst in the jaw or face, what are we actually talking about? Because I think most people just picture, a lump filled with pus.
Yeah, that's a common idea, but it's misleading here. The lack of pus is actually the crucial point. According to the definition Kramer laid out back in '74, a cystic lesion is a pathological cavity, could be in bone or soft tissue. It might contain fluid or semi-fluid stuff, even gas. But critically, it's not formed by pus accumulating. So definitely not an abscess.
Got it. No pus means it's more structural, less about an active infection fight. Is that the main thing for a pathologist?
That's a huge part of it, yes. And what's more, for something to be a true cyst, it needs three specific things.
Okay.
First, there's the central space, the lumen. Second, the connective tissue wall, the capsule. And third, the really defining part, an epithelial lining.
Okay, so that lining, or whether it's even there, that's the big divider.
Precisely. You've got true cysts, like a radicular cyst, fully lined with epithelium. Then you have pseudocysts. Think of a solitary bone cyst. They lack that epithelial lining. And that difference structurally changes everything about how it behaves.
Right, and that makes the basic difference clear.
Yeah.
So how do we start classifying these jaw cysts more broadly?
Well, we usually start with that lining. Is it epithelial or non-epithelial? And then we look at where it came from. Was it inflammatory, maybe from an injury or infection? Or developmental, meaning it grew from those leftover tissue bits we mentioned.
And under developmental, you hear odontogenic and non-odontogenic. Just quickly, what does odontogenic mean here?
Odontogenic just means coming from tooth-forming tissue. So tissues that built your teeth but left some dormant cells behind in the jaw. If a cyst pops up from those, it's odontogenic. If it's from other facial tissues, it's non-odontogenic.
Makes sense. But the growth mechanism, that seems like the really fascinating part. It's one thing to have a cavity, but how does it generate enough force to push aside and even destroy hard bone? I mean, these things can get huge, even cause fractures.
It's basically a hydrostatic pressure bomb driven by osmosis. It happens in two stages: initiation, then enlargement. But the main driver for enlargement is simply an increase in the volume of what's inside the cyst.
Okay, pressure buildup. But how does the fluid inside get chemically denser than the body fluids around it so it pulls water in?
It starts with the cells lining the cyst. These epithelial cells shed off, they desquamate, and once they're floating in the cyst fluid, they undergo autolysis.
Autolysis, big word. So the old cells basically dissolve themselves. Is that the gist?
Exactly. They self-digest. Large protein cell bits, they break down into lots and lots of smaller molecules. And just the sheer number of these tiny molecules ramps up the osmolarity of the fluid inside the cyst dramatically.
So it becomes like chemically thicker or more concentrated than the blood serum amounts now.
Precisely. And Toller actually measured this. The average osmolarity inside a cyst is around 296 milliosmoles. Compare that to serum, which is about 282.
Wow, that's a tiny difference on paper, only 14 milliosmoles. Can that really generate that much force?
Enough to move bone. It creates what's called the dialysis effect because the inside pressure, the osmotic pressure, is higher. It just pulls water transudation, exudation from the surrounding tissues right into the cavity.
Like a sponge.
Exactly like a sponge. Fluid rushes in, volume goes up, the internal hydrostatic pressure skyrockets, and that pressure pushes on the nearby bone, forcing it to resorb, to basically get out of the way.
It's quite an amazing, if destructive, bit of biology. So the pressure eats away the bone.
Yeah.
Does it also encourage the cyst lining itself to grow bigger?
It does. It creates this nasty cycle of expansion. We call it mural growth or epithelial proliferation.
Oh, okay.
That constant internal pressure plus the release of bone-resorbing factors like prostaglandins from the cyst wall actually stimulates the epithelial cells in the lining to divide faster. So the lining's surface area increases, which lets it generate even more osmotic pressure, and the whole thing just keeps getting bigger.
So this elegant destructive physics applies to all these cysts. But, some are way more common, some much more aggressive. Let's apply this pressure idea to the main ones we see in the jaw. Maybe start with the most common.
Okay, yeah. That would definitely be the radicular cyst, sometimes called an apical periodontal cyst. It's inflammatory, and it's the big one makes up over half, about 52% of all epithelial jaw cysts.
Inflammatory. So where does it actually start?
It comes from these epithelial leftovers called the rests of molasses.
Rests of molasses.
Yeah, these are just tiny dormant bits of the tissue that formed the tooth root. They just sit there, usually doing nothing, but they get activated, they start growing. If the tooth pulp dies, becomes non-vital, usually from decay or getting hit.
So inflammation from a dead tooth wakes up these sleeping developmental cells. What's the classic look on an X-ray?
Typically, it's a round or oval dark spot, a radiolucency, often with a distinct dense white border around it, what we call sclerotic. And critically, it's always connected to the root of that dead or dying tooth.
Okay, that's the common inflammatory one.
Yeah.
What about on the developmental side? Tell us about the dentigerous cyst.
Right, the dentigerous cyst. Its whole definition is about its relationship to a tooth. It forms when the follicle, that's the tissue sac around a developing tooth, separates from the crown of a tooth that hasn't erupted yet.
So it looks like a bubble wrapped around the top of a tooth stuck in the jaw.
That's a good way to picture it. Its unique feature is that it attaches right at the neck of the tooth, the cemento-enamel junction, and it completely surrounds the crown.
And where do you usually find these?
About 2/3 of them are around unerupted wisdom teeth in the lower jaw, but you also see them pretty often with upper canines that are stuck.
Okay, now, let's get to the one that seems to raise the most red flags in the material. The odontogenic keratocyst, or OKC. This one feels different. Why is that?
The OKC. Yeah, it really needs special attention. Its behavior is just fundamentally different. Yes, it's a cyst, but its growth doesn't seem to be just about hydrostatic pressure. There seem to be, well, unknown factors within the epithelium itself driving it. It has this relentless growth potential. The cells divide really fast, high mitotic value.
I saw that some researchers even suggest calling it a benign cystic neoplasm, not just a cyst. That's a huge leap, right? Suggesting it's more like a tumor.
It is a big leap, and it's because its behavior acts more like a tumor than just a simple fluid bag. Clinically, it's infamous for being silent, asymptomatic, until it gets massive.
Sneaky.
Very sneaky. It tends to grow along the inside of the bone, in the medullary cavity, before it starts visibly pushing the outer bone cortex.
And that leads right to its major problem.
Yeah.
It comes back alive.
Absolutely. The recurrence rate is notoriously high, and there are reasons for that. The lining is often incredibly thin, like wet paper, making it super hard to remove completely without it breaking apart.
Right.
Plus, new cysts can actually pop up from tiny satellite cysts left behind in the bone nearby, or even from the basal cells of the normal mouth lining overlying the area. It's a real challenge.
And there's a major clinical link here. If you see a patient with multiple OKCs, what should that immediately make you think of?
Multiple OKCs. That should always make you suspicious of Gorlin-Goltz syndrome. It's also called nevoid basal cell epithelioma syndrome. People with it get multiple basal cell skin cancers, the OKCs in the jaw, and other issues.
Wow, okay. That's a critical connection.
Yeah.
Now, shifting gears a bit, away from bone to the soft tissues. We see fluid-filled things there too, especially with salivary glands. What's a key symptom if a patient has a problem there?
The big clue is mealtime pain and swelling. If the swelling and pain really kick in when they eat or even think about eating, it strongly suggests the gland's duct is blocked, often by a stone, a calculus.
And structurally, what are the types of cysts here? You mentioned extravasation versus retention.
Yeah, it's about where the fluid goes. An extravasation cyst is basically a leak. Saliva escapes the duct or gland and gets trapped in the surrounding soft tissue. A mucocell is a common example, or a ranula.
Okay.
A retention cyst, on the other hand, is a blockage. The fluid gets trapped inside the duct system because something's blocking the exit.
And tell us a bit more about the ranula specifically.
A ranula is just the name for an extravasation cyst, that leakage type, specifically from the sublingual gland under the tongue. So it shows up as this bluish swelling in the floor of the mouth. Sometimes if it gets really big, it can dissect down through the muscles into the neck. We call that a plunging ranula.
Okay. So whether it's a common radicular cyst or a tricky OKC or one of these soft tissue things, eventually we get to treatment. What does all this pathology mean for the patient, and how do clinicians decide what to do?
Well, first step before any surgery is aspiration. Sticking a needle in is crucial.
Really? What does that tell you?
It's surprisingly useful. Just looking at the fluid, the color, the consistency, and analyzing it can really help diagnose.
Can you give an example? How does the fluid differ?
Sure. An OKC aspirate, for instance, it's usually kind of thick, creamy, whitish. Looks a bit like pus, but isn't.
Yeah.
And chemically, it's got low protein, less than 4 grams per 100 milliliter. A dentigerous cyst, though, that usually yields clear, yellowish, straw-colored fluid. And it's got high protein, often over 4 grams per 100 milliliters. That simple test can point you strongly towards one diagnosis or another before you even make an incision.
That's a neat clinical pearl, tying back to the biology. Okay, so after aspiration, what are the main surgical approaches? Let's start with enucleation or cystectomy.
Enucleation is basically the gold standard, if possible. It means completely removing the entire cystic lesion, shelling out the whole sac in one piece, ideally. The rule of thumb is enucleate whenever you can.
And the big advantage is,
Well, you get the whole thing out for the pathologist to examine, which is ideal. And, you've treated it hopefully completely in one go, excisional biopsy, essentially.
but the downside must be the risk, especially if it's big.
Exactly. The risks are real. You could damage or devitalize nearby teeth. With very large cysts, there's a significant risk of fracturing the jaw, either during the surgery or soon after. And you always worry about nearby nerves or other vital structures.
Which logically leads to the alternative, the safer option, marsupialization or decompression.
Right. Marsupialization, or sometimes called cystotomy, is different. You create a surgical window into the cyst, clean out the contents, and then you stitch the edge of the remaining cyst lining to the surface mucosa, like the inside of the cheek or gum.
So you turn the cyst into a pouch open to the mouth.
Kind of, yeah. The rest of the lining is left behind in situ, and the idea is that with the pressure gone, it will gradually shrink over time.
It sounds like, as you said, a safety net. When would you choose this over just taking the whole thing out?
The main reason is safety. For really big cysts where the fracture risk from enucleation is just too high, or if the cyst is wrapped around something vital like the main nerve in the lower jaw, and you absolutely cannot risk damaging it.
Makes sense.
It can also be used sometimes to help an impacted tooth erupt, like with a dentigerous cyst, you unroof it. So the rule here is more like decompress the really large or risky ones, even in OKC sometimes, initially.
But the obvious drawback is
Yeah.
you're leaving diseased tissue behind, right?
Yeah. That's the major downside, yes. You've left pathologic tissue in situ. So it usually means the patient needs a second surgery later, once it's shrunk, to remove the remainder, or at least very long-term monitoring. And it's a hassle for the patient, too. They have to constantly irrigate this cavity to keep it clean while it slowly heals in. So if we sort of pull this all together for you, the listener, what really stands out is that amazing efficiency of the cyst growth mechanism, that tiny osmotic difference, creating enough force to reshape bone.
Yeah, the physics is incredible.
And we've hopefully clarified the big difference between something common like a radicular cyst, which is just inflammation gone wrong, and that high recurrence OKC, which behaves, well, maybe more like a benign tumor.
Right.
And finally, that really tough clinical decision surgeons face. Go for the definitive removal with enucleation and its risks, or play it safer with decompression, but accept leaving tissue behind, at least initially.
And the distinction you just made between a cyst acting like a neoplasm, that's what I want to leave our listeners thinking about. We talked about how some view the OKC as more like a benign tumor because of its growth pattern and recurrence. If its behavior is fundamentally driven by the epithelial cells themselves, not just the fluid pressure, does that change how we should think about other conditions where epithelium grows excessively? Where do we draw that line between a cyst, which we think of as relatively simple, and a tree neoplasm, a tumor? If the lining is the engine, not just the container, well, it raises some big questions, doesn't it?
It certainly does. Food for thought.
Thank you for diving deep with us today. We hope you feel better informed and maybe even inspired to explore this more.